Natalie,
Hello.
thank you so much for coming along to visit us in.
Thank you for having me.
And you've had a tough old day today, haven't you?
It's been a bit of a journey.
So tell me how logistics worked out for you today.
Well, today I was working cross-site. So I work at Chelsea and Westminster Trust. So I was at Chelsea Site Hospital this morning, came across to have the meeting with you guys today. And then I'll be heading back there because I've got a couple of things to do.
Oh, my goodness. You've come all that way just for primary care?
Just for primary care, but I am predominantly based at West Middlesex Hospital.
Oh, I see.
Yeah.
So what is it? How does that work then? What sort of stuff do you do at Chelsea and what do you do at West Mid?
So at West Middlesex, I lead the early pregnancy unit and I do gynecology, ultrasound scanning. So I have a one-stop ultrasound gynecology clinic. And I also lead the Sonata service. I don't know if you've heard about Sonata, but this is ultrasound guided.
Not the Frank version. Frank Sinatra.
Not Sinatra, Sonata.
Oh, okay.
Yeah. So it's an ultrasound guided radiofrequency ablation of fibroids. And it's done through the vagina, through the cervix. And I lead that cross-site. So sometimes I go to Chelsea site to assist with Sonata. And other times I do it at West Middlesex Hospital.
That sounds amazing. Is that a relatively new thing?
It is relatively new, maybe about 3 years.
Okay.
And it's incisionless, so no cuts. It's a fantastic service.
Presumably you have to have a general anaesthetic.
You don't. So
it's just like having a scan, but you're...
Yeah, it's probably a little bit more similar to hysteroscopy. So the kind of pain relief options we have for hysteroscopy. So we have the option of asleep or awake. We have Penthrox gas, so they can breathe that gas for the awake procedure.
And then how does it work then? Is it?
So
it just fizzles.
Yeah, it uses radiofrequency energy, which then heats the fibroid, and then it shrinks over the coming 2 to 3 months.
How does it target fibroid tissue opposed to?
Yeah, so because it's ultrasound guided, a really tiny ultrasound probe goes inside of the uterus, and it allows you to look and see exactly where the fibroid is to then target it. And then on the ultrasound screen, you can map how big the fibroid is so you know exactly what you're treating.
And you can see it melt away.
You see it begin to get very white as it begins to get treated. And then in a couple of months, it shrinks significantly. And you get significant improvement in heavy menstrual bleeding.
Oh, I see. Because actually lots of things were developed. This is a fun fact. Lots of things were developed in the military, weren't they? And then scanning and then it has medical uses afterwards. So this must have been something that was developed in...
Perhaps. It's definitely, radiofrequency energy is being used for loads of things. Aesthetics, treatment for the skin and all sorts. So you can target it in terms of how strong, how high the energy is. And then with Sonata, it's ultrasound guided. So you map exactly what you're going to treat. What you don't want to treat, you don't treat. It's a great procedure.
Thank you. I'm so sorry we got carried away.
Hello,
we're going to go back to... so talk me through, take you back all the way to when you were, say, 16 and deciding what you want to do.
It was before that.
When did you decide to medicine?
I think I decided somewhere around 11, 12, like when I was starting high school. Yeah. So my mother was the chief nutritionist for the Department of Health. So I come from the Caribbean. I'm from Trinidad and Tobago.
Oh, nice.
So my mother was the chief nutritionist, and there were times for the whole country. Right. So there were times that she would pick me up from school and I'd have to wait in the hospital while she finished off some meetings or things that she had to do. So I spent a lot of my childhood and my young years, kind of just hanging around,
Meeting rooms.
hanging around the hospital. Yeah.
Did you pretend you were a consultant
I
then?
did not, but I roamed and I walked around, and when they had sometimes meetings in the nurses section and all sorts. And so I spent a lot of my time in the hospital. Yeah.
That's the ultimate work experience, isn't it?
There you go. There you go. And I had some uncles who were doctors, and the combination of all of that, my parents saw my interest. And so, you have to choose your subjects pretty early.
Yeah,
so
you do.
I knew that I wanted to go along this route.
But sometimes when you're surrounded by people in the medical field, that actually can kind of put you off a bit, can't it?
Yeah, but I saw good things. And on top of that, I've got, my mother is one of 6 sisters, and I've got lots of female cousins, and I just wanted to take care of them. And so even when I decided I wanted to do medicine, I knew I wanted to do obstetrics and gynecology.
Yeah. Did you have any other things in your mind when you were 16 or was it always just razor focused on medicine?
Always medicine. It was always medicine. And then it very quickly became gynecology.
Was gynecology, did you decide that at university or before or after when you did your rotations?
While I was at university. So while I was doing my rotations.
What was it that, you seem to be like a pretty focused person, and you kind of try something and you think, do you know
and then I'm like, this works. I'm going to keep doing this. Yeah. I saw my first vaginal birth, and I thought it was amazing and it was beautiful. I did cry. And, the mother was probably wondering what's wrong with this medical student sitting in there crying. This is my experience. Why are you having an emotional time? Exactly. But it was really beautiful. And I went to medical school in the Caribbean, and we get a lot of hands-on as medical students. So suturing and seeing patients, and you had a lot of responsibility and a lot of development, which was really fantastic. So, I kept thinking, I'd tell my friends, hey, you know what? I think I want to do gynecology. And they'd be like, Natalie, you told us that last year. I'm like, it did? Well, okay, this just confirms it then. This is for me.
Look, most people think like, the big 2 things that you think about is like medicine or surgery. And then within surgery, you think, all the different specialties. But for you, it was just straight to obs and gynae.
Yeah, but women's health is both surgery and medicine.
That's a fun fact, actually, that we picked up in one of the other.
That's right.
It's one of those few surgical specialties where there's lots and lots of medical treatment in there as well.
That's right, yeah.
And it covers, the younger people, older people, and everything else.
It's the full span, really, of a woman's lives.
Yeah.
From birth to,
Put it like that. Yeah, everyone's going to be leaving general practice and going into
it's great. And then you can kind of choose where you have your best aptitude, what things interest you the most. Are you better with the young people? Are you better with the more mature persons? You can
find your little
You can find your niche, yeah.
Do you but we're going to a typical day for you. So apart from today when you're going
back
to Chelsea, all the way to Hounslow and then back to Chelsea again, what's a normal day for you? What does that involve?
So I would say a normal day would start around 8:30. We meet and we do a ward round to review all the gynecology patients who are inpatients, deciding who needs an ultrasound scan or who doesn't, who needs surgery, who doesn't, and who can go home. And then I work in the early pregnancy unit, which also includes acute gynecology. So often I would do the scans for those patients who are on the ward who I've just seen. And I continue to do that for the morning. And then the afternoon, I might have a little bit of administration or teaching or general gynecology clinic, and all my clinics are one stop. So I scan all my patients at the same time. I try for not, you come, you see me, then you go, you have a scan, you come back to see me. I do everything at the same time if I can, make a plan for treatment. And then if it's one of my on-calls, I then go to labor ward at 5 p.m. Until 8:30 p.m. So, women who are birthing, in labor, cesarean sections, and then I'm on call for the night.
The whole night?
Yeah, so I'm on call from home after about 8:30 p.m., but then I may need to come back in depending on what's happening.
Pretty intense, isn't it?
That is an intense day, yes.
How often do you do the on-call?
I do it, it's 1 in 9. So it works out on average every 9 days.
And then what about weekends?
That includes
weekends as well?
That's correct. But the weekends are kind of split. So it's actually 2 in 9 because one is a Friday, Sunday, and one is a Saturday because you can't do the entire weekend. That would be too much and you wouldn't be safe.
I mean, in the olden days, not sure, I'm obviously not.
Yeah.
I used to work 9 o'clock on Friday until Monday, 5 o'clock. And I remember, actually, funnily enough, I used to be an SHO, and the surgeon did something called a myomectomy clinic, where those operations where they take out fibroids, but they take, I'm obviously not an expert in it, apart from holding a clamp but those operations take hours and hours and hours and hours. And I used to finish at 6, 7 o'clock on a Monday when on call. So
after working the weekend.
After working but you learn a lot, I suppose.
You do learn a lot. And that's, part of the challenge of training now. We have to find the balance, work-life balance, but at the same time, not sacrifice training.
Do you do research as well?
I do.
Go for it. What are you studying?
Well, I did a research degree. I did an MD degree at UCL on ultrasound of ovarian tumors. So once again, ultrasound, ovarian tumors.
Okay.
Looking at the features, when should we do something, when we shouldn't. Some of our treatment plans are quite interventional. We remove a lot of these, and quite a lot of the time these are benign. So being able to assess them properly.
Benign as in not cancerous.
Benign, not cancerous. So being able to assess it properly, to be able to give the right recommendation to the patient so they know, should I have this removed? Should I leave it alone? Will it cause me a problem in 5 years? So should I do it now? That sort of thing. So I did that research. But since then, most of the research I'm involved in is in the early pregnancy unit. Okay. So a lot of things like on ectopics or miscarriages. An ectopic is a pregnancy inside of the tube, so not inside of the uterus where it will grow to become a baby, but when it's inside of the tube is too small, and so that baby can't survive.
Okay.
And then also miscarriage studies. So the PRISM study I was involved in.
What's the PRISM study?
The PRISM study, really fantastic study. It looked at women with miscarriages and if they have bleeding in their next pregnancy, if they're given progesterone, it improved the outcomes and reduced the risk of miscarriage. So right now, it's completely changed our practice. If any patient has had a previous miscarriage and she has bleeding in a subsequent pregnancy, as long as we've confirmed the pregnancy is in the right place, we can give them progesterone therapy and reduce the risk of miscarriage.
Oh, right. And what are the chances of that miscarriage risk being reduced with progesterone?
So there's a really good chance, and the more miscarriages someone has had, the greater the effect and the benefit, and it's statistically significant. Really, really good outcomes. And, it's really good when we see research that women, offered themselves up to be studied and to be part of the study. And now it's come full circle and providing benefit to these same women.
Actually, we were speaking to Achana earlier, and she highlighted the fact that research in women's health is not significant, is it?
Yeah.
It should be much more.
Yeah.
And often we're being treated using research data on men.
That's right. That's right.
So
it's a really good thing for women to allow themselves to be part of research. There's so much benefit. And they think, okay, it's not going to benefit me, it's going to benefit somebody in the future. But actually, it's been shown that it does benefit that person because you get greater care, you get greater support. And so we, our women who've been part of studies continue to contact our research nurse and our research midwife to continuously connect with them when their next pregnancy comes along. It's really fantastic. And so I really would want to pitch out to women out there. You've got a health condition. You've got, when the doctor or the nursing clinic offers you to be part of a research study, it really is quite beneficial.
Yeah. Yeah. Early pregnancy, fraught with stress. So how can you, if somebody has pain in early pregnancy, say in the first month or so, what should people, what sort of things should people worry about, and what things should be reassuring?
The first thing I would say is that bleeding is never normal in pregnancy. So once you have a positive pregnancy test and you have some bleeding, it needs to be checked out. Pain can often come from where the egg came from on the ovary that formed the baby. And so a lot of the times it's nothing serious, but it still needs to be checked out. So we have a really low threshold. If somebody's got pain and or bleeding in early pregnancy, we see them in the early pregnancy unit to check. And the first thing we want to check is, where is this pregnancy? Make sure it's in the right place. And then secondarily, we want to check that it's the right size and that it's growing normally.
Because the right place, the ectopic thing that you mentioned earlier, that's potentially life-threatening, isn't it?
Yes. So an ectopic pregnancy is life-threatening, especially if you don't know you have it. So for a woman who knows that we've diagnosed an ectopic pregnancy, we sometimes do conservative management and they can go home. Yeah, if the hormone levels are low, they have no symptoms, there's no bleeding inside, and we can follow their hormones.
I did not know that.
There you go.
Two things I've learned.
So they, and they may be absolutely fine to go home. They know what symptoms to look out for. The ones we worry about are the patients who are not keeping track of their periods. They don't realize they've missed a period. They're having some bleeding and they think, oh, maybe it's my period, but it's not. It's bleeding in pregnancy. And then they leave it so long that if they do begin to have bleeding inside of their tummy, then it becomes an emergency.
And just speak to your GP.
Speak to your GP. You can call 111 and 111, especially in Northwest London now. You may not know this. We have a system in place. If patients call 111 and they're pregnant, pain or bleeding in the first 3 months, they call 111. 111 can book them into the clinics in Northwest London.
I did not know
the early
that.
Pregnancy units.
That goes back to what you said earlier about the fact that you try to do everything for the patients in one go. And actually that includes
That's right.
Because all we do in general practice is, make sure they're hemodynamically stable, but then book it into the clinic. And actually you can go straight there.
Exactly. So if a patient is very unwell, they still need to go to urgent care or to A&E. But if they're well and they've just got some spotting, some mild pain, they can call 111. We book them in, usually within 24 hours. If we can't, then we check another unit, which might be able to do it within the 24 hours. And then you get your appointment for the scan, because the important thing at this point is to see where the pregnancy is.
And the scanning is really quick, isn't it? It's not like other services. So normally when we refer to at the early pregnancy unit, it's done like pretty much the same day. Normally,
exactly. So it's usually the same day, or worst case scenario, the next morning.
So can you dispel some myths and misconceptions around bleeding in pregnancy? What do you think? What do you think come across that people think is true but actually isn't?
The main one I would say is that I don't like the term implantation bleed. if you have any spotting in pregnancy, it needs to be checked. We can't just assume that that's an implantation bleed. It can't, that needs to be checked out. So never ignore bleeding in pregnancy.
So that's a really good point. So what is bleeding? Is a speck of blood?
Speck of blood.
The tiniest drop?
Tiniest drop.
Even if you're not sure?
Even if you're not sure.
Even if you haven't got pain and you feel well?
Even if you haven't got pain and you feel well.
And I think that is really important to get across because actually what you're saying is just kind of come along and we'll get that scan.
Yeah. And if it's fine,
it's fine.
You've not wasted our time.
No.
We are there to check and make sure that it's fine for you.
Because if nothing else, you know that egg is in the uterus.
That's
and
right.
Not in the
in
tube.
the tube. Yeah.
Fibroids.
Yeah.
Misconceptions around fibroids. What is it that people believe which simply isn't true?
My
biggest,
my biggest thing about fibroids is women ignoring heavy bleeding and thinking that the heavy periods is normal and thinking that it's normal to put towels on your bed at night, or it's normal to walk with a change of clothes because you're on your period, or that it's normal to be changing a pad every hour, or feeling dizzy. I think my biggest thing for women is about heavy periods is to do a self-assessment in terms of those symptoms. If you're bleeding for more than 7 days, you're having to wear double protection, things on your bed, change of clothes, soiling your clothes, passing clots. All these things are not normal and should be assessed. You need to see a GP. They can get a scan. They can check your blood count. And the earlier you manage fibroids and heavy periods, the less invasive the options are for that treatment. And you don't end up with needing a huge myomectomy. I mean, some people will still need that, sure.
A myomectomy is...
Yeah.
What
a myomectomy, you mentioned that operation. I know.
But I can't remember what it is now. It's such a long time ago.
A myomectomy is an operation where we go into the tummy to remove the fibroids.
But you don't remove the whole.
But you don't remove the whole womb. You just remove the fibroids from the womb. And sometimes women need that. But I think that too often I see women who've left their heavy periods too long. And not too long, but by the time they come, it's a lot more difficult for us to help you. So I would encourage women, if they think their periods might be heavy, get it checked, get it assessed, so that if you do, we can find the cause. And if you do have fibroids, we can start the treatment plan a lot earlier.
And that's, I think, a theme that's coming through in a lot of these podcasts. In that women are delaying things and they're being told sometimes by other women or parents or relatives or men or partners, and that it's okay, that this is normal bleeding.
Yeah.
The bleeding you described is normal. It's not.
And it's not. That's
so
right.
we sometimes see patients with hemoglobins of 60, for example. It's so low, and that doesn't happen immediately. It happens over a long period of time.
Yes.
So I suppose the big take-home message is to just get advice early if it doesn't feel right.
Yeah,
just have a chat and get some baseline investigations done, tests done, and then if they're okay, then that's completely okay.
Yeah.
Cool. Thank you so much for coming along today.
No problem.
And I'm sorry you have to go all the way back to Chelsea.
That's all right. Thank you very much for having me.
We'd love to come and visit you, actually, in the early pregnancy unit.
Please do.
And give people an insight into what